Thank you, Sandy, and thank you, Dr. Brown, for this opportunity to present a topic that is near and dear to my heart, trauma-informed age-appropriate care, a new paradigm for the neonatal intensive care unit. Learning objectives for today's session. Upon completion, I hope you'll be able to describe the impact of toxic stress on the developing brain, be able to list 3 traumatic experiences of a hospitalized infant associated with their NICU stay, and identify 3 evidence-based age-appropriate care strategies that mitigate the toxic stress experience of the newborn intensive care unit. So stress. We use this term very frequently, and I think we've become quite desensitized to what stress really is. There's really 3 different types of stress. There's positive stress. That's the kind of stress that you may feel before you take an examination, maybe before you speak to a large group of people. That's when your HPA axis gets flipped on and you start squirting out some cortisol and increasing your circulating levels of catecholamine to prepare you for that focused action that you need to take. And then after you've begun the activity that initiated the stress response, you kind of settle into this new homeostatic state. So that's positive stress. It's good for you, and it helps people adapt to different situations. Tolerable stress are those situations that can be actually distressing to us, but we can get through these difficult situations through the company or the presence of someone else who's there to kind of hold our hand and get us through these difficult situations. That's what's defined as tolerable stress. But the topic at hand is really about toxic stress. And toxic stress is that prolonged and sustained activation of the hypothalamic pituitary adrenal system in response to stressors when there seems to be no end in sight. It's a constant. It can be even chronic. And this is the kind of toxic stress that changes biology right down to the genomic level. What I'd like to do is share this video from the National Scientific Council on the Developing Child, and they do an excellent job really describing what this phenomenon of toxic stress is all about.
Learning to deal with stress is an important part of healthy development. When experiencing stress, the stress response system is activated. The body and brain go on alert. There's an adrenaline rush, increased heart rate, and an increase in stress hormone levels. When the stress is relieved after a short time, or a young child receives support from caring adults, the stress response winds down and the body quickly returns to normal. In severe situations, such as ongoing abuse and neglect, where there is no caring adult to act as a buffer against the stress response stays activated. Even when there is no apparent physical harm, the extended absence of response from adults can activate the stress response system. Constant activation of the stress response overloads developing systems, with serious lifelong consequences for the child. This is known as toxic stress. Over time, this results in a stress response system set permanently on high alert. In the areas of the brain dedicated to learning and reasoning, the neural connections that comprise brain architecture are weaker and fewer in number. Science shows that the prolonged activation of stress hormones in early childhood can actually reduce neural connections in these important areas of the brain at just the time when they should be growing new ones. Toxic stress can be avoided if we ensure that the environments in which children grow and develop are nurturing, stable, and engaging.
And so creating nurturing, stable, and engaging relationships in the newborn ICU can really be a challenge to us. I also want to just point out the original work looking at toxic stress really did revolve around this concept of early life adversity, early childhood trauma. Whoops, sorry about that, guys. You know, so when you were listening to that, you might be thinking, well, gee whiz, you know, these babies, we're not abusing them, we're not neglecting them, we're taking care of them. They're in a critically ill situation and truth be told, a life-threatening situation. We now know through some really great research looking at PICU survivors that medical trauma also activates a toxic stress cascade. And so, understanding that when you take a look at this infant, and this is just an image I got off of Google, I don't know this person, but does this child look like he's comfortable? Does he look calm? Or does he look like he may be distressed and possibly experiencing toxic stress? Notice the light shining in his eyes. Notice his left forearm where there's a tourniquet still wrapped around, and if you can really see clearly, that proximal portion of his hand and wrist is discolored. There's an alcohol prep positioned near his ear, very close to his nose. His nares look like they may be flaring a bit, and his brow, although it's obscured somewhat by his hand, it does to me look a little bit furrowed or worried. He's got so much tape across that upper lip area, it's almost coming down to the level of his mandible. Now, I'm completely understanding of the need to secure lines and tubes, but we really don't need to go to that length. Think about removing that tape and how much pain is going to be associated with that experience, with that procedure. So certainly this infant is experiencing stress, and I don't see any adults around. I don't see anybody offering him hand containment. I don't see him being held by his mom or dad. So more than likely the stress that he's experiencing is indeed toxic. And as we heard from the video, sustained activation of the stress response system does lead to long-term impairments, alterations in the neuronal architecture, specifically around learning, memory, and emotion regulation. Toxic stress also changes the brain mass. And so here's some images, MRI scans, of 2-3-year-old brains. The brain on the left, under the normal category, is a healthy individual who had no early life adversity. I don't know the details of this person's life, but it is considered a normal brain. The brain on the right, this individual suffered extreme neglect, and although did not experience any medical complications, did experience extreme social and sensory deprivation. And look at how much smaller this brain is. This was a survivor of the Romanian orphanage. Toxic stress is the extreme, frequent, or extended activation of the stress response without the buffering presence of a supportive adult. And that's really the key phrase here. Bad things are going to happen in the newborn ICU, right? These guys are in a life and death situation. They need to be there if they will survive. But what we need to be mindful of is that their biological needs are not to the exclusion of meeting their human psychosocial needs. Because we're bigger than the sum of our parts, right? We need to have attention to all of these things, particularly during sensitive and critical periods of development. This Smith et al. Paper was published in the Annals of Neurology, and it was a really great evaluation of trying to link stressful situations with neurological findings. So this group in their, I think it was 2009 paper, they developed the Neonatal Infant Stressor Scale. And basically, they had a group of interdisciplinary professionals sit around the table and list all of the things that they considered to be stressful to the patient in the NICU. And this ranged from intubation, chest tube insertion, surgery, to mouth care, having leads put on, vital signs, being nursed on a radiant warmer versus being nursed on an incubator. I mean, soup to nuts, NG tubes, the whole 9 yards. And after they corroborated with all of their identified stressors, they then weighted them, indicating that probably a chest tube insertion is a lot more stressful than having EKG leads placed, but both are stressful in their own unique way. So after they weighted them, they then looked at a cohort of infants over the first 2 weeks of admission to the newborn intensive care unit and scored them. And then they compared the scores to the brain imaging scans that they obtained. So row A in this image, that's the control group. These are the healthy term controls. And you can see, again, and I'm not a radiologist, so I'm probably not going to do this great service in interpreting, but the takeaway message is look at the balance of the images here. You can see that there is interhemispheric communication, nice and evenly distributed over this entire normal row. The row B here, these are the infants that had the low scores. They had stress, but from a numeric perspective, they were on the lower spectrum of stress scores. And you can start to see that there is a change in the symmetry of the images, right? That there, one side is more lit up than the other. So something is changing in the brain here. Row C category, these are the infants that had high stress scores, high NIS, Neonatal Infant Stressor Scale scores. And there's almost no intrahemispheric communication, that the image on the right is not balanced on the left. And the conclusions that they drew from this study was that high stress exposure is indeed associated with differences in the brain, both anatomically and functionally, suggesting a vulnerability to the preterm brain to stress. And they then went on to say that this actually may be linked to potential neurodevelopmental outcomes. And again, more and more people are doing this evaluation. And so it's an exciting time to be part of neonatology, because all of this evidence is coming to bear, and we can then be informed and improve the service that we're providing to these infants. So, gee whiz, you're probably wondering, you just jumped from toxic stress to trauma. Is there a link between these two terms? And indeed there is. Trauma results from an event, a series of events or set of circumstances that is experienced by the individual as physically or emotionally harmful or even life-threatening. And this event will have lasting adverse effects on the individual's functioning and mental, physical, social, emotional, and even spiritual well-being. Now, SAMHSA, the Substance Abuse and Mental Health Services, were the first ones to start really investigating this idea of trauma, trauma survivors. I mean, I can tell you myself, when I first was delving into this subject matter, I really viewed trauma as something like a gunshot wound or a drowning victim or something traumatic happened to you. You survived the tsunami, you survived a fire, you survived the gunshot wound. But in fact, trauma is not specific to medical catastrophes or natural catastrophes. These are experiential catastrophes that do change our biology. And there was an amazing study that I'm going to introduce you to that will really bear this out. But before I segue into that, I want you to really understand and embrace this concept published by the National Scientific Council for the Developing Child, that these early emotional experiences do indeed become embedded in the architecture of the brain. And I know that many of my NICU colleagues would argue with me that these individuals, these infants, don't have the capabilities to have an emotional experience or an emotional response. And in fact, that is completely false. From a biological perspective, they do have the structural capabilities. And actually, folks have looked at this under different types of imaging studies, that there is emotional activity going on in these individuals. The insular cortex is one of those primary mediators, but it's not just the insular cortex that's active in responding to emotions, the brainstem and the subcortical structures as well. And these are fully formed by the second trimester. So we know these individuals do have the capabilities. Now, of course, I can't ask them if they're having an emotional experience because they're pre-verbal and they have limited behavioral skills to express their emotions. But I think this is where the art of what we do comes into play. And we need to truly walk in their shoes and empathize with their experience. We share our humanity. Don't be fooled in thinking that these individuals are less than or different than us. There are fellow humans. We need to really honor that and acknowledge that. So these trauma experiences, we actually, you don't have to throw your hands up. We can actually do something about it. And it's through the application of this new concept, at least new for neonatology, of trauma-informed care. The concept of trauma-informed care actually has its origins in mental health, in response to traumatic stress. And trauma is a widespread public health concern, both for, the abuse trauma, the neglect trauma on the social scale, and also medical trauma as well. Individual trauma results from these events or series of events that are experienced by the individual as physically or emotionally harmful or life-threatening. and they have these lasting adverse effects. We can change that, and I'm going to show you how. But remember when I mentioned to you about this study that really kind of started connecting the dots for us as healthcare professionals? And the study was done in the mid to late 90s, and it was called the Adverse Childhood Experience Study. And this study was initiated by a group out in California, Kaiser Permanente, along with the CDC. What they were discovering were that people with some significant health challenges, to include hypertension, cardiac disease, obesity, they were discovering that these people had a history of adversity during childhood, and they wondered if there was a connection. So what they did is they surveyed over 17,000 patients in their network, and these were white middle-class people that they thought, we won't find much here, but let's just ask, let's just investigate some of these suspicions that we have. So individuals were asked about physical abuse, sexual abuse, emotional abuse during childhood, household dysfunction, and varying degrees of neglect. And what they discovered, that in the 17,000 people, 87% of the respondents identified experiencing at least one of these adverse childhood events. And then, usually when they saw one, they actually saw more than one. And as a follow-up in really examining the details of this study, they discovered that individuals with 4 or more reported ACEs, things really started getting bad. And these individuals had a 390% increase in the likelihood of developing chronic pulmonary lung disease, hepatitis, 460% increase in suicide risk, 5,000% increase in risk in becoming an IV drug abuser. So this was really blowing them out of the water. They were just, baffled by this. And, a lot of different people have replicated these studies across different demographics, and it has all borne out that adversity in childhood changes our biology. It changes our developmental trajectory, and it changes us at the genomic level. Here are the mechanisms by which this adversity in childhood influences our health and well-being. So if you look at this pyramid at the bottom, and you see this arrow over here with conception and death, because again, it's not just at birth that individuals experience adversity. We know lots of prenatal situations that create hostile intrauterine environments for the developing fetus, and this also changes their biology. So this adversity disrupts neurodevelopment. These individuals are dealing with a toxic stress situation. So they've got a prolonged activation of the HPA axis. Their body is saying, we've got to figure out how to survive. And it's at a brainstem level and an amygdala level. The amygdala is that subcortical structure that's responsible for very strong emotions, usually fear-originating emotions, that really change the focus of the development at that time to pure survival. How am I going to survive in this situation? If you think about a baby, if a baby's needs are not being attended to, that is a life-threatening situation. Are you with me? And that changes how these neural networks are getting laid out. And so everything starts from the bottom up. And so if you have disruption at the beginning, then it's going to change what the blueprint originally, the genomic blueprint originally had planned for this individual. And things start going off the rails. These individuals experience social, emotional, and cognitive impairments. And what that does is it changes a lot of those neurohormonal systems, the serotonin system, the dopamine system, the oxytocin system. All of these things get changed in a very critical way. These individuals then go off to adopt health risk behaviors, which then increases their disease vulnerability. They go on to have social problems, and because this influences the biology at that genomic level, what they're now discovering is this transgenerational transmission. So these vulnerabilities or susceptibilities actually get passed on to the next generation and the next generation, even if those individuals don't experience toxic stress themselves. So it's a pretty significant situation, and it's a really big deal. I urge you guys to check this information out. Just type in a study, it'll blow you away. Now, taking that idea of early life adversity and bringing it right down to the premature patient population has been the work of this group of Italian researchers, Monterosi and Provenza, and they've done lots of really cool stuff around the patient population that's near and dear to our hearts. And they've identified that preterm birth is indeed an early adverse experience. And it is related to the NICU stressors and the quality of care. And it's not the medical care that these guys are talking about. It's the quality of caring that they experience. One of their earlier papers actually looked at the quality of developmental care at a cohort of 25 different NICUs in Italy. And they were just looking to see, were there any correlations to outcomes related to the quality of developmental care. And they created this little quality of care checklist, and it basically reflected the core measures for developmentally supportive care, which was the work of myself and Sharon Gibbons and Stephen Hoth, and also some indicators from the NICU program. And they compiled it into a little checklist, and they went around and they assessed all 25 NICUs and their quality of care. And then when the patients reached corrected gestational age of 32 weeks or were medically stable, they then did a neurobehavioral assessment on this patient population. And what they discovered is the infants that were cared for in environments where there was high infant-centered care practices and high infant pain management care practices, their neurobehavioral assessments were statistically significantly better than they were in any of the other NICUs. And then they actually recently just published a paper, I want to say it's 2016. They looked at quality of life indicators in that cohort of survivors at 5 years of age, and they had a statistically significant improvement in their quality of life when compared to the other groups that they looked at. So I hope I'm expressing this clearly to you guys. And again, check out these authors. They're doing some really amazing work. So what are these NICU-related stressors? What are these trauma experiences that we see in the NICU? Well, it's physical stressors, right? The light, the sound, which affects us as well. But sometimes we minimize that and we say, oh, we can't turn it down, the lights down because we can't see. I need to talk, there's monitors, blah, blah, blah. The number one contributor to the sound environment or the sound pollution in a NICU are the human beings in that space. Skin breaking procedures, that's another trauma experience of these individuals. Heel sticks, venipunctures, IV starts, NG tube insertions. It's not skin breaking, but it's an invasive procedure. Ostomy bag changes. All of these are traumatic experiences. They elicit a toxic stress situation for the infant, particularly when they are not supported by a caring adult. And I'm not trying to say that any of you guys that are listening to this are not caring professionals. We have a million competing priorities on our plate. We're trying to get all of this stuff done and move on to the next patient. But what we need to be mindful of is in that moment of caregiving, particularly when it's a painful or a stressful caregiving encounter, who is there for the baby? Who is going to support that infant throughout this stressful situation? And you may be throwing your hands up and saying, you're crazy, Mary. We're all too busy. We're too short-staffed. We don't have enough people to do four-handed care or two-person care. Well, I'm telling you now, you need to figure out how you are going to change that then, because it is going to, the results of continuing to not manage this pain and this toxic stress of these infants, you are creating a maladaptive next generation that will be the society of the future. The number one traumatic experience of a hospitalized infant or infant anywhere is maternal separation and alterations in maternal caregiving. These little individuals are programmed to expect a continuation of that dyadic relationship that they have with their mother. How do we facilitate that? Or do we actually discourage it? Oh, the baby's sleeping now, so you can just sit here and look at your baby through the fish tank of the incubator. Oh, I just put him to sleep. We can't do kangaroo care now, or whatever reasons. And again, listen, I didn't fall off the turnip truck. I've been there. I know what happens. The way we used to do it is wrong. We need to change the paradigm. We need to move towards zero separation. If you look up the work of Niels Bergman, if we continue these practices, we are going to continue to undermine and malign the developmental trajectory of these individuals. And so surviving is not it. That is not the end of the journey for us. Getting discharged home is not the pat on the back. The pat on the back is the quality of life that these individuals are going to enjoy or miss because of their toxic stress experiences during the newborn intensive care hospital stay. I talked about this genetic phenomenon, this epigenetic impact that these developmental exposures have on these individuals. And these, again, transgenerational influences, clinical events, nutrition, how are we feeding these individuals? Lifestyle. I mean, while they're in the NICU, it is their life. They're in this environment. What are the social stressors? Are we distancing the family from the infant caregiving, or are we partnering with them? Are we collaborating with them? Looking at environmental chemicals. You know, we had a lot of this talk about the phthalates and, you know, changing the pacifiers and the plastics that we're using. But the environmental chemicals are much more than that. There was a really cool little study that looked at the air pollution inside the incubator. And that when they did a chemical analysis, one of the higher toxins in the environment were aerosolized alcohol, phenols in the air. And one of the suggestions was when you use those hand sanitizers, before you put your hands into the incubator, let that stuff dry off. Don't go in there with the hands still moist, because when you do that, that's going to evaporate into the environment. And when you close those doors, there's no place for that gas to go. It's stuck in there. And that also is a developmental exposure that can influence the phenotype of the infant through this epigenetic activity of methylation and histone modification and that sort of thing. And these exposures are linked to later life outcomes. And I'm going to show you more of those outcomes in a second. So again, back to my Italian colleagues, as they really started digging in and understanding this, they started asking the really critical question: if indeed we know that these exposures, this early life adversity, is changing these individuals at the genetic level, aren't we ethically responsible then to do something about it? And I obviously say, yes, we are. And what is it? What are we going to do about it? We know the developing brain is vulnerable. And I've got this up to 40 weeks, but in fact, it's the first 5 years of life that human beings really figure out what the world is about and adapt coping mechanisms that align with their experiences. So if they've had loving, nurturing experiences, even through adversity, then they're going to have a different view and a different way of expressing who they are in the world versus somebody who has had experiences that have been painful, isolative, frightening. They're going to move through the world with that as their experience, you know, kind of driving them through the world. And the behaviors that you see in those individuals are not functional. They're not adaptive in today's society or in any society. These individuals are profoundly susceptible. And so how can we manage this experience in a more meaningful way and change how their brains are going to get wired for the better? Critical and sensitive periods of development really revolve around that synchrony of relationships. And it's these positive relationships that we have with each other and with our patients that activate oxytocin. Oxytocin is the antithetical hormone to cortisol. Oxytocin is that hormone that makes you feel good, makes you feel connected, makes you feel safe. And that gets activated through human encounters. But when we don't facilitate that, when we don't have those positive relationships, then we're changing how the brain is going to get wired. And, you know, I have relationships with my patients all the time, but they may not always be nurturing. They may be very task focused. And if there's, you know, my nursing colleagues are listening out there, you know it's true, right? You check out your assignment, you have 3 patients, they're all 8, 11, 2, 5, you're thinking, how am I going to get this done? You just line them all up, and you go in, you pop the doors, you reach in, you flip and strip, and you just start doing all the tasks that you need to get done at 8 a.m. for each of those infants. You're having a relationship with that person, but it may not be an ideal relationship. And I know it's hard. And I know we have some time constraints, we have staffing constraints, we have all this kind of stuff. We do need to figure out a meaningful way of resolving that, but not at the expense of the infant. And I invite you, the next time you put your hands on the patient, take a few seconds and just collect yourself. Use GRACE. GRACE is a really cool acronym that was developed by this Buddhist monk who worked with palliative care professionals, and they were experiencing a lot of compassion fatigue. And so she created this acronym. G means gather your attention. Before you put your hands on or open the doors, gather your attention. And R, recall your intention. What is your intention? Your intention is not to get the vital signs, change the diaper, do the feeding tube, blah, blah, blah. Your intention is to manage the experience of this individual, this hospitalized infant, ease their suffering in some meaningful way. A, attune to where the infant is at. Is the infant sound asleep? Or are they in distress? What are you going to do? C, consider your options. And then E, engage. Engage with the infant, or maybe if they're in a sleep state, go and check out if the next patient is ready for a do-up. But when you finish that encounter, I invite you to then end the experience by the same way I hope when you begin your exchange. When you put those hands in, you're not flipping and stripping, but maybe you just put your hands on the baby's head and on their lower extremities and give them a verbal greeting before you start your activities. Just let them attune and acclimate to your presence. And then when you're finished doing all your stuff, I invite you to do the same thing, and frame the care encounter. And I think what you'll find is the infant will settle in a lot more comfortably after the encounter than they have in the past. We know that those first 2.5 to 3 months of life is when the highest rate of synaptic formation of the sensory pathways is happening. You can see it's on the yellow line here. This is from Nelson Pediatrics. And that's vision, hearing, audition, well, that's hearing, olfaction, gustatory, all of the senses are really having a high rate of synaptic formation. And really, all of that sensory input is really supposed to be the parents. Their smells, their taste, the sound of their voice, the taste of their skin, the sound of their heartbeat when the baby is lying on their chest. All of these really wonderful, what it feels like to be on mom or dad's chest and being moved around. That vestibular input, that security, that love that bathes those neural pathways and allows for optimal proliferation. But when we don't provide that, those synapses do not form. Remember that video of the toxic stress, and those connections are just melting away, and it changes who they are. Babies are cool people, and they interpret the world, what the world is, from the bottom up. And the bottom up, I mean their brain. It's at the brainstem level where they either experience stress or distress, anxiety, something's not right, I'm afraid. That fear bit gets, kind of translated from the frequency of the heart rate, right? When we're chill and we haven't done any aerobic activity, we have a resting heart rate. And that means that we're fine and we're chill and we're happy. But when we're getting anxious or worried about something, our heart rate goes up. And the same thing happens for the babies. And we all have this capacity for what's called neuroception, when we become aware of something around us that doesn't feel right or feels relaxed and sends a signal to our brainstem that we're okay or we're in danger. And that's how babies operate. It's not about rationalizing, the nurse is coming to me, I think they need to draw blood, so I better just kind of, knuckle it up and be okay. That reasoning part of the brain is not developed yet. We as human beings, we figure out all about the world based on how it makes us feel. How do you make your patients feel? The number one trauma experience is maternal-infant separation or parent-infant separation. How are we moving towards minimizing that and truly eradicating that? Additional trauma experiences, as I alluded to on the previous slide, skin-breaking procedures. How consistently are you making sure that you're using some kind of non-farm strategy for every single heel stick that infant undergoes? and not after the fact. Say, oh, I always use sucrose, and then I immediately lance the heel. Are you using sucrose properly? Are you waiting the 2 minutes? Are you monitoring the infant throughout the procedure and redosing as indicated? And are you doing this consistently, or when you think about it, or when you think you have time for it? It has to be done all the time. In regards to parent-infant or mother-infant separation in particular, Howard et al. Did this really cool analysis and uncovered that in these in their cohort of patients, well, or a study group, an occurrence of 1 week or longer of mother-child separation during the first 2 years of life was related to higher levels of child negativity and aggression at ages 3 and 5. So this stuff, it bears out. And these were not NICU survivors. These were regular kids. So we know that separation has a negative effect on healthy individuals. Imagine what it has on vulnerable individuals that are in a critically ill, life-threatening situation. Psychosocial deprivation in any caregiving encounter must be viewed with as much concern as the debilitating disease that the child is enduring. They're not too true and unrelated. We are bigger than the sum of our parts. I'm going to show you this next video.
Everyone in a community has a vested interest in everyone else's children, because everyone else's children determine the next adult population that makes for a successful society. Built into our biology is the need to have responsive interactions with adults.
Neglect for children is when they don't get what the brain is expecting to get, what the child is expecting to get, what we are biologically prepared and waiting for, which is input from those around us.
It's this back and forth serve and return interaction that literally shapes the architecture of the brain.
Serve and return begins when a child looks at something or observes something, makes an utterance, and that represents the serve. And the return is when the parent notices the child doing these things and responds to the child.
Under conditions where serve and return is broken, you literally are pulling away what is the essential ingredient of the development of human brain architecture.
It was a really compelling series of experiments where they started by videotaping the mother and the baby engaging and cooing and smiling. And then they asked the mother to basically put on a blank face and not respond at all. When a baby is not attended to, that is a sign of danger to the baby biologically. So the stress systems become activated.
In a brain that is constantly bathed in stress hormones, not that's up and down, that comes with normal development, certain key synapses, the connections between nerves, fail to form, and critical regions of the brain. So neglect both fails to provide the stimulation that's needed to develop the basic architecture, and when it's at a certain level, is one of the most potent activators of the stress biology of a young child. So you get a double whammy.
Science points to 4 categories of this spectrum of neglect. The first category would be what's called occasional inattention, where children experience responsiveness most of the time, but occasionally adults don't respond. There's no harm in that, and in fact, there's probably some benefit.
A child can learn to self-soothe and explore the environment, and all of those opportunities build brain architecture.
The second category, scientists would call chronic understimulation, is where on a regular basis, children have less interaction with the adults around them than is needed for healthy development.
Those children typically, when provided with enriched learning opportunities and more typical levels of serve and return, will show catch-up.
The third category is what science would call severe neglect in a family where not only are there prolonged periods of inattention, and lack of responsiveness, but often also associated with not being fed enough, not being bathed enough, not having basic needs met.
Neglect is a huge problem in the U.S. Children are much more likely to be neglected than they are to experience any other kind of maltreatment.
We see the child really being at risk for much more substantial kinds of deficits down the road that don't necessarily get easily fixed or ameliorated. This is where we really need to think about more complicated and often more intensive strategies to help undo those effects.
The fourth category, called severe neglect, generally found in institutional settings, is a result of children living in kind of warehouse-type situation in orphanages.
And it doesn't have to even be as extreme as orphanages. It can be experiences that are regretfully occurring in many, many parts of our country.
Often institutional care in this country is under the euphemistic name of transitional care or temporary care or assessment facilities.
If you think about what institutional or residential care would look like for an infant, where there's somebody new coming onto the shift every 8 hours, it really alters the development of the child's brain architecture and other aspects of the child's development.
We have the potential to change children's developmental trajectories.
Interventions can apply to parents, to foster parents or adoptive parents, child care settings, Head Start settings, and other kinds of settings. And really, what they're about is attuning people to the serve and return process.
Neglecting young children is neglecting the foundations of a healthy next generation. The community pays a huge price later in terms of the problems of the next generation, whether it be educational achievement, economic productivity, good citizenship, the ability to parent the next generation. All of the things that have to do with a healthy, prosperous society.
And I'd like you to consider hospitalization as another version of an institutional environment. And so what are some of these outcomes associated with the next generation when they begin their life in a newborn intensive care environment or a hospital setting? 50 to 70% of infants born preterm go on to develop internalizing and externalizing problems. Those are precursors to things like depression and acting out oppositional defiant disorder. And I'm sure you're all familiar with their increased risk of attention deficit hyperactivity disorder, which now folks are suggesting that in NICU and PICU survivors, we look at these behaviors through a trauma lens and consider that they actually may be manifestations of post-traumatic stress disorder. In a term cohort, infants that were hospitalized for congenital heart disease were at increased neurodevelopmental risk for compromise for if they had a longer post-op length of stay, which had nothing to do with their severity of illness, but pretty much everything to do with, again, them being cared for in a less than optimal environment. Hospitals are not home. They're not, a traditional nursery environment. They're meant to be functional and, they're aimed at sterility and all that kind of stuff. They're not nurturing, warm and fuzzy places. And so it's not just premature people that are at risk, but the data does support a lot of adversity associated with, or morbidities rather, with premature survivors. There's a significant increased risk of violent suicide in infants born prematurely. And I want you to connect the dots between what I'm sharing with you here and the ACE report and the ACE results. An increased risk in cardiovascular disease in adult. Also, premature people are at a higher risk for fibromyalgia as adults. And an increased risk of metabolic syndrome and obesity in premature survivors or NICU survivors. Compared with their term counterparts, infants that are born prematurely are at significantly higher risk for developing some pretty profound mental health disorders, to include schizophrenia, depression, and bipolar. And you can see here, the more premature you are, the higher your risk is for developing these diseases. And these are a lifelong sentence of compromised quality, of constant medical and psychiatric hospitalizations. It's really tragic that these are the outcomes in this group of patients. So why should we care? Because we know that toxic stress is a mediator of early childhood adversity, and suboptimal outcomes are a result of experiencing these early life adversities. And for us, if we can understand the biology, then that opens up new opportunities for us for primary prevention and early intervention. And I'm not talking early intervention post-discharge. I'm talking about during the NICU stay, primary prevention and early intervention in the NICU. If indeed you adhere to this, first do no harm, we have huge opportunity for improvement in the service that we're providing these infants. What's really cool and exciting, at least from my perspective, is the AAP is getting on board. They issued a series of technical reports and other publications addressing this idea of toxic stress and actually integrating this new science as a kind of like the framework for pediatric care. So here's the lifelong effects of early childhood adversity in this technical report in 2012. Here's a new science of early childhood. This is another 2012 publication. This one is in treating the role of the pediatrician in addressing toxic stress. And yes, they are focused on outpatient situations, but I think now in the wake of all the information we have about pediatric medical toxic stress and pediatric medical trauma, and now this latest publication from Degata et al. That came out in Advances this year in 2016, looking at infant medical trauma in the NICU as a conceptual model to help us frame the experience, where she defines the 3 trauma experience as pain, separation, and stress. We're really kind of starting to dig in and realize that these individuals need more than just attention to their lines, tubes, and their diseases. They need some serious and consistent attention to their human developmental needs. And so I put forth that the mitigating avenue for us to march down is adopting these core measures for age-appropriate care, that will help us, as now being trauma-informed, to mitigate the toxic stress. The age-appropriate term, we basically pulled that from the Joint Commission, where they have an HR standard that requires all healthcare professionals, all, not just NICU, all, meet the age-appropriate needs of the patient population they serve, which is different, right? When you're a newborn, your age-appropriate needs are different than when you're an adult. And so what are these age-appropriate needs of the developing infant? Well, number one, it's maternal proximity. It's access to their mom and dad constantly. I'm not even going to say once a day. It's constant. We need to move to zero separation. If we can just do that, we can really change the tide on a lot of this long-term morbidity. Remember Erik Erikson and his life stage virtues? That first year of life, it's all about basic trust versus mistrust. And what that means is basically, how does the individual experience the world? Do they see the world based on their experiences as a place that's safe and secure and trusting and their needs will get met? Or is it a really scary place where it's catch as catch can and somebody might be nice to you, but more often than not, bad things happen to you. So you move through the world very defensively. And again, imagine how that is going to play out when you're 2, when you're 6, when you're 20, when you're 50. Here's the model that the AAP now is using as the basic science for pediatrics, where they're now saying that the ecology of the developing individual, the social and physical environment, impacts the biology. And the biology is those adaptations and or disruptions that change the individual right down to the genomic level. And those changes and adaptations or maladaptations impact development for learning, behavior, and health across the lifespan. So these core measures, the original work I mentioned was from Sharon Gibbons, Stephen Hoth, and myself. Frustrated with the inconsistency of developmental care, we wanted to be more clear about what does developmental care look like. So we again adopted the Joint Commission's concept of core measures, where we looked at evidence-based practices in caring for infants. And after we, pored over the literature, we organized what we found in these 5 categories. And these are quantifiable things, okay? And these categories are protecting sleep, preventing, assessing, and managing pain and stress, and also involving the family in the pain and stress management plan. ADLs, how we support posture, the feeding experiences of these individuals, and skincare practices. Family collaboration or partnership, family-centered care, whatever term you want to use, and then the healing environment. And looking at the healing environment, not just from space, light, sound, but the human component of the healing environment. How well do we get along? How well are we communicating with each other and with the family and with the infant? And then the systems environment. How well does the organization in which we work support us in doing these evidence-based best practices? In 2011, this concept was adopted by the National Association of Neonatal Nurses and became the clinical practice guideline. And just recently in 2016, my second book, it's called Trauma-Informed Care in the NICU, Evidence-Based Clinical Practice Guidelines for Interdisciplinary Clinicians. It, again, has been endorsed by the National Association of Neonatal Nurses with recommendations from Dr. Heidi-Lise Alves of the NIDCAP and the Synaptic Theory, Carol Kenner, Sue Ludwig, and Ann Stock, a neonatologist from Vanderbilt who I worked with at the Brigham and Women's Hospital. We're really moving to a place where we now realize meeting these human needs, these age-appropriate needs, is clinically relevant as well as socio and psychologically relevant for the infant and the family. And, you know, when we look at providing these practices, it isn't about doing it when we can, when we get a chance, when we have good staffing, when we've had our second cup of coffee. It's about doing it all the time. Because think about it, if, you know, usually the people that are on this call, you're all part of the choir, and you probably do this stuff all the time. But if you're one out of 200 staff, or even out of 20 staff that does it all the time, that's the baby's experience of care is going to continue to be inconsistent. We're really talking about changing the paradigm, making this a standard, and not just a standard that sits on the shelf, a standard that lives and breathes in the culture of care. I'm actually putting on a Beacon workshop in February as a pre-con to, well, it's not associated with Graven's conference, but it's the day before the Graven's conference. And it's really going to talk about that and how we can create actionable plans to change the paradigm, to consistently and reliably providing these evidence-based practices around zero separation, around oral feedings and breastfeeding and cue-based feeding, around skincare practices, around responding to the alarms of these infants, being responsive to their distress, or just, you know, well, it's not my patient and I don't have time to go over and comfort and soothe that child. And I know this stuff happens. I was in a NICU, and there was a clinician at the desk next to the infant in their little bed space. The child was crying, and that person never turned away from whatever the heck they were doing on the computer. Writing orders, charting, doing, I don't know. And why? Because it wasn't their job. We have to change that. We need to have a no-pass zone. You start walking past an infant's bed space and they start expressing distress, their alarms going off, whoever is within ear's reach needs to respond. Only then are we really going to start changing the paradigm. What's interesting is this whole idea about missed care. So I'm a nurse, and, you know, I do prioritize the care that I have to provide. I only have 12 hours in a shift. I've got to get X amount of stuff done, and I'm not alone in doing this. Nurses across all different specialties prioritize their care. These guys have researched this phenomenon in NICU, but Kalish is the one that started this whole thing about looking at missed or rationed care in the clinical setting and really examining not only the frequency, but the fallout. And that's what these guys have done. They've looked at the frequency and the fallout. These are the most frequently missed cares, self-reported by nurses in the NICU. Participation in rounds. You don't show up in rounds, you don't get to advocate for your patient. Discharge planning. You do poor discharge planning with a family, dollars to donuts, they're going to be readmitted within 30 days. Oral care for ventilated infants. Educating and involving parents in the care. Comfort care. And Rochefort and Clark, and actually a few other authors, just recently in 2016, published another paper looking at this comfort care and discharge planning and the fallout of that, of those results. And Tubbs and Cooley and Pickler looked at the oral feeding. So I'm a nurse. I have 3 babies. They're all, starting to build their skills in oral feeding, but maybe I'm behind on my schedule. And the patient that I'm caring for is showing all the right cues for an oral feeding encounter, but I decide to gavage instead because I don't have enough time. What we find now in this work of Tubbs, Cooley and all, is that you're going to contribute to a longer length of stay in that group of patients. So this is what we need. We need people to start really looking at this and connecting outcomes to these phenomena so that we realize these are important, and looking at how our systems are helping us achieve all of this. Because again, I know how busy you are. I know you're all short-staffed, but collectively, creatively, we can come up with solutions so we can hardwire this paradigm in a meaningful way into NICUs across the globe and help the next generation, help the future. But what we need to really think about is minding the gap. That's the biggest thing here, because I could talk until I'm blue in the face. I love this subject. I can spew as much research as I've gotten my fingertips on, but it's really up to you and us to do something about it. The gap is the knowledge and action gap. You can send everybody and his brother to a conference. It doesn't mean that anything's going to change when they all come back. There needs to be a concerted effort by everybody, by all disciplines, to figure out how are we going to overcome the challenges that exist in the delivery of these best practices, and test them out. You may not come up with the first solution right out of the gate, but there's you're creative. I know as a nurse, we are like the queens and kings of workarounds. And I mean, although that might not be the best thing to do, what it does highlight is our creativity and our commitment to the patient population we serve. Use that for good. Use that to figure out how are we going to overcome these things. You can't be throwing your hands up and saying, well, we're just short-staffed. There's nothing I can do about it. Yes, there is. You're not looking at the problem the right way. We need to speak the language of administrators to figure out what will push their buttons, what will get them jazzed up about this, and measure. What gets measured gets managed. We need to look at this differently. It can happen. It has happened in some NICUs. It's easier to build strong children than to repair broken men. And in fact, you can't repair broken men. I got introduced to this concept during a brief stint as an interim nurse manager in an inpatient adolescent psych unit, which is a whole other story. But it was in that setting where I discovered NICU survivors in a psych setting, and it was already a day late and a dollar short. These children now, the rest of their life was going to be hard and fraught with hospitalization, poverty, pain, and just heartache. And once they turn 18, what do? We wipe our hands and we say, oh, well, they need to fix themselves. You can't fix yourself for the most part. So we can help make that a never event, or at least the least often event than is happening right now. A person is a person, no matter how small. And each and every one of you guys listening to this, you can't unhear what I just said to you, what I just shared with you. I'm not saying you have to take my word for all this stuff. Go do your own due diligence. Check out, I've got a pretty cool, extensive reference list that I'm happy to share with you guys. But I need you to start having these conversations. Please, reach out to me, email me. I'm happy to work with any of you guys, share any information that I have. You can check out my website as well. And I want to thank you very, very much for your time today. It really means a lot, and I know you're very passionate about the work that you do. Take care and happy holidays.